Fidelma, thank you so much for talking to me on a Sunday from Northern Ireland, Sunday morning after you've come back from walking your dogs, and Sunday evening just before dinner for me.
It's a delight to see you again, even if it is only virtually. So I'm really, really happy that you asked me to do this. I've been following your vlogs and they're brilliant. I've really, really enjoyed them and learned a lot from the experiences that you've been able to share.
Thank you. I've been really reflecting on some of the themes across them. Thank you for the feedback. It's been a lot of fun. I feel very privileged to be able to do that. It's taken us a while to get our act together to make this work. So I really appreciate it, Fidelma. So Fidelma, you're now, from the beginning of this year, a senior consultant at the Northern Ireland Health and Social Care Leadership Centre, yes?
Yes.
Having spent prior to that 15 years at Unison as a trade union organiser, the largest union in the UK, you've had a really diverse range of places you've worked. You've worked in youth services. Your first role was at a newly founded women's centre in a Protestant working class community. That would have been an interesting role.
Yeah, well, it was for me because I'm originally from the Republic of Ireland and I came north to go to university here. I'm also Catholic, so I suppose I was working in an area, in a Protestant, quite loyalist area, with a very southern accent, which marked me out, and also a Catholic background. And it was at a time of quite high tension. It was the Garvaghey Road protests. I think the interesting thing for me, coming as an outsider, I was less of a threat to the women that I worked with because I was an outsider. And therefore, it allowed me to have very interesting conversations because I came from quite a place of ignorance, even though I only grew up 8 miles from the border. It was a whole other world. So yeah, it was a fantastic learning experience for me. And I suppose it really opened my eyes to the other side, even the concept of the other side, and hearing the stories of people on the other side, because I felt I was kind of on the other side as a Catholic and maybe even further removed as somebody from the Republic of Ireland. But actually listening to the women's stories about growing up in working class Protestant and loyalist areas, and then also listening to women's stories who talked about growing up in working class Republican areas, while their experience of say, the security forces was different, their experience of the Troubles, their experience of growing up in working class poor areas where there was a lack of services, where aspirations for education were lower, where people were genuinely struggling, where there were a lot of people were growing up maybe in single parent households, then those experiences were common. So I think what it really started me thinking was the importance of storytelling.
Yeah, which you are very good at. Actually, one of the things I might do, if it's all right with you, is put a link when we send out the newsletter that will have this blog attached to it, to the idea about some of the storytelling. Can you just briefly talk about some of the storytelling processes that you've been involved in?
Well, one of the most lovely ones is something called 10 by 9, which was started in Belfast by Padraig O'Toole and Paul Doran about 5-6 years ago now. And it's a monthly storytelling night in a venue in Belfast. 9 people come together and tell a story which can be no longer than 10 minutes, hence the 10 by 9, must be true, and must be about yourself, and is along a kind of vague theme. So you get these lovely vignettes of people's lives. And indeed, the 10 by 9 kind of concept is now kind of almost global. So there are similar storytelling nights in other places all over the world, including one in Melbourne.
Yes, which you found. I was so incredibly impressed that you knew more about some interesting things going on in Melbourne when you arrived than I did. Fidelma, I'm going to leave that as a taster, and I'll put something in the newsletter so people can track it down and have a look. But you've had a really strong commitment throughout your career to social justice. 30 years as an activist in LGBT, and as you started out as first female president of the Ulster Student Union.
Second, I have to qualify. No, I was the second.
So, strong history of social justice. What I'm curious about is what you bring from that to the role that you have now at the Leadership Centre.
Well, the Leadership Centre is a regional, I suppose, leadership and management training organisation for the health service. So we provide a whole range of, I suppose, engagement opportunities. So we'll go out and work directly with teams. We have a range of regional leadership programmes. Ultimately, it's about supporting staff, and we have 66,000 staff who work in the health service in Northern Ireland, so right across all factors, all disciplines, all levels. And it's about ensuring that there is good leadership. So we have one of the big kind of, I suppose, big ticket items and strategies we have now is around collective leadership. And it's about a recognition that leadership is at all levels. And that translates then into a kind of a range of programs which tries to support teams, looking at things like the Aston model around team identity, around team decision making. So it's about making sure the teams work better and supporting them to be more engaging, because when they work better, then you're going to have better outcomes. And also we will provide a whole range of courses. So one of the most recent ones, which of course we've been trying to move online, was called Managing Difficult Situations. And in moving it online caused us to have a whole relook at it in terms of how you break it down. And one of the things that we actually did was we changed the title. So we moved it from Managing Difficult Situations to Having Difficult Conversations. And the reason was, from my perspective, that when you have the word managing in a course title, there are loads of people who will look at that course title and think, that's not for the likes of me, because I'm not a manager. And they will immediately say, no, that's not. And I think similar, when you have leadership in a course title, a lot of people will look at it and say, that's not for me. That's for people more important than me. That's for people who are higher up than me. And actually the collective leadership strategy is saying, actually, no, everybody is a leader. And in order for us to make that real, then we have to give everybody those leadership skills, the language, the values. I'm not saying that people don't have the values, but actually to recognize that the values they already have are leadership values. And that is often through conversations and actually supporting them to realize that, and then supporting them to use those values and bring them to work every day and actually live those values in their work. And where people have behaviours which they'd like to improve, then support them how to do that. So one of the things about having difficult conversations is that everybody has difficult conversations. Or conversations that you would just like that if they went a bit better. If you had more control over the outcome of the conversation, if you could use language which supported you to have a better outcome, if you can use language that reduces the possibility of conflict, or where the conflict emerges in a conversation, that you can use language in order to de-escalate that conflict. And those are things that people can learn. So in terms of leadership, it's important to give people, whether you are a cleaner or a catering assistant, and I'm using those as examples because they are some of the lowest paid staff in the health service, whether you're a clinician or senior manager or a chief executive, actually everybody can benefit from having those tools and skills and having those conversations and being able to reflect on your practice. Because while a lot of, say, clinical disciplines would have reflective practice built into the way that they work, yes, right, social work, yes, or nursing, a lot of people come into the health service in lower paid jobs, whether admin or cleaning or sterile services or catering, and they see it as a job, not a career. So they don't really reflect, because they're not encouraged to reflect on, could this be done better, because that's for somebody else higher up to tell me, they get paid to do that kind of thinking, not me. I just come in here to do the job. But actually the experience has been that when you go in and work with groups of staff and genuinely create opportunities for them to reflect on the work and make suggestions on how it can be improved and be listened to, and action taken on those suggestions, again, you get a better outcome. And I think what the really interesting thing about the COVID response was the way in which it broke down hierarchies and silos, both between professions in terms of encouraging and forcing more in multidisciplinary work, people moving into new roles very suddenly because of redeployment, and maybe roles that they had kind of always taken in ways they'd always done things. Everything was up for grabs because nobody was quite sure what to do. So you had two types of control. You had very much a command control. So the Department of Health said, we're in charge and these are things that need to be done. So that certainly at a strategic level, there was a command and control in terms of trying to get a handle on the response to the pandemic. But in workplaces, there was very much of, how do we do this? Does anybody have any ideas? And everybody was open to hearing from other people and encouraging other people to give their opinions and ideas. Whereas in I suppose, the traditional workplace before that, people had their roles, everybody had their place, and everybody respected the hierarchy. So in COVID, I think it really, really opened up opportunities for people to take on a new role, to put forward ideas that people thought, that was fantastic, I didn't even know you could do that or that. And the other thing that I think really helped was that there was money. So it was like, before that, people had really good ideas, and they said, oh, yes, yeah, oh, yeah, that's a really good idea, but there's no money, but the structure doesn't allow it, but the governance doesn't allow it, and suddenly these good ideas, we're able to, yes, that's a good idea, and it makes sense, and it'll help. Let's just do it. Let's not go through 10 committees. And I'm not saying that governance got completely thrown out the window, but the layers of decision making were stripped back in terms of that people were willing to try things. So there was that kind of check and challenge. Let's try it. If it doesn't work, we'll try something else. So the last few months, I think, have really opened up workplaces and given people new experiences. People have gone in and been in leadership roles to people who are much higher levels of seniority. So I read a really good blog about a consultant who'd gone into a COVID intensive care environment. And he talked very humbly, in that he came in from a discipline. He knew nothing about intensive care. He'd done his 1 day's training or whatever many days training they got. And the way in which he had to be led by those who are intensive care experts. Yeah. Even if those were a healthcare assistant in that intensive care ward, or a nurse who would have been in seniority terms much, much further down the traditional chain. He was just saying how fabulous it was. He wasn't saying in any way that, he felt demeaned in any way. He was reflecting in a way that everybody went in, they listened to each other, the leadership came from wherever the knowledge was, as opposed to the hierarchy. And I think women in particular have benefited from that. And we do have a lot of women in very senior roles in the health service over here. But I think women who are in less senior roles were suddenly in very much leadership roles within wherever their environment was when they're working within COVID.
Fidelma, I think it's really fascinating listening to you, because I'm hearing very similar kind of themes here, that the humility of leadership, that no one person has the answer. So how do we kind of open source good ideas and much faster decision making, that kind of try, test, learn, that we all know works and we aspire to, but it's been happening much more frequently in the crisis. I think one of the things that's going to be a real challenge is, how do we hold on to that? How do we hold on to the good elements of the processes that you've described as we transitioned into recovery phases? What have you got any thoughts about that? How do we hold on to it?
Well, it's one of the things that we've been looking at in the Leadership Centre, because you're right, it would be quite easy for people just to go back to talk about a new normal. But actually, it's still quite easy for people to go back into their traditional roles, as people move back out of redeployment and some of the services that have been suspended resume. We've been looking at a tool which really, like a framework, which asks a series of questions around, what did you have to stop that you now need to start doing again? What did you start doing that you no longer need to do anymore? What did you start doing that we'd really like to hang on to? So start identifying those. And one of the things that's been really interesting is the move for us to video consultations with health professionals. Now, probably, I'm sure in Australia, because the rurality of it and the size of it, Australia's probably been using that technology much more effectively than we have. In Northern Ireland, the presumption was you didn't get a proper consultation with a health professional unless you were sitting beside them. Right. Yes. Even if they didn't touch you, even if there was no clinical examination needed, so there's two issues. One, the clinicians didn't feel it, but also the member of the public didn't feel it. If they only got a phone call, they almost felt shortchanged in some way, right? Whereas because people couldn't come into hospitals or even GP surgeries, the video consultations, I think one of the health trusts did over 100,000 consultations by phone or video in the first 2 months or 3 months of the COVID pandemic. They would have said, well, the technology is not there. It's not safe. There's not encryption. There's all these barriers. So there were people who wanted to do it. But again, there were all these barriers given. Suddenly it could happen. Suddenly the encryption was sorted out. Suddenly, let's try this. Yeah. Whether will we try Zoom? Will we use WhatsApp? Will we try Microsoft Teams? Whatever. And that's been really important. There's also been an emphasis to try and keep people out of hospital. And again, that's been an aspiration in every big strategic plan for the health service over the last 10 years. How do you reduce hospital stays, reduce people coming to ED? And it's always been, well, you put more services in the community. But actually, they've never really put enough service in the community to make that happen, in the most effective way. So now, initiatives like we have acute care at home. So a number of the trusts had an acute care at home program, whereby instead of, say, an older person or somebody who needed IV antibiotics, traditionally would have had to come into hospital for a number of days or no number of nights, been stabilised and then released. So instead now, the GP identifies they need antibiotics, the acute care at home team goes in, sets up the IV antibiotics in their home, and it means, it's much better for them, much better for not coming into hospital, much better in terms of, the hospital, in terms of that bed being available for an emergency or for surgery. And that was done on a relatively small scale in a number of trusts. And really, a lot of the trusts are looking at really, well, how do we ramp this up? Because this is really effective. So how do we put more resources into that? How do we put more resources into social care? How do we ensure that social care that's provided by the independent sector, which for here is the kind of profit sector, is sufficiently as good as that is provided directly by the public sector, the trust themselves? Because again, there's been real issues around the type of delivery. Now, from a union point of view, as a former trade union activist and still a union member, we would like to see those roles brought back into, this is a personal opinion, not the opinion of my employer, but to bring those roles back under the public sector, because we think that staff will get better working conditions, better training, certainly better pay than many staff are getting in the private sector at the moment. And I think personally it was also stabilise and allow that social care model to kind of grow in a consistent way. Now things are being looked at in a way, whereas before there was an element of tokenism, an aspiration. So I think there's been real key changes, and people are really thinking, well, how do we genuinely do things differently? How do we sustain the things that were good, that we had to do, that we learned from? And how do we also, I think, look at what other people are doing? Because the interesting thing for me about the COVID pandemic is that it was a pandemic. Every country in the world has had to respond, and I think there's a real opportunity to learn from, how did Australia respond? And right now, Victoria, unfortunately, is back in lockdown, and, you've got an increasing number of live cases. And so you are now in your second wave. We're coming out of lockdown slowly, but everybody, in the health professions are saying, yes, but we're expecting a second wave. Right? So I think we need to be learning from you who are trying to cope with the second wave in a winter situation, because it's your winter now.
Yes.
I think that's what we need to do now. As we're starting to come out, we need to be starting talking to people who've had different types of responses, because you have a different model of healthcare. I think even that's interesting, because that'll have forced you to respond differently than us. And there's learning in that.
That's right. Fidelma, I think there's a phenomenal amount that we can learn from each other, and things have happened at different rates in different stages. And I am very curious to keep talking about what you've just described in terms of some processes to think about. What is it that we hold on to? What are the things that I think that stop, start, continue kind of framework about? There are some things that we've had to do in this time that we actually don't want to keep doing. None of us want to keep doing, that we don't want to always have to wear masks when we go, shopping or out. But at the moment we have to. It's mandatory here at the moment. And I think there's very good reasons for that. We've crossed some incredible thresholds very fast to make the adaptations that are much better for the communities. And there's some incredible parallels between what's going on in Northern Ireland and what's going on here. So let's keep talking, Fidelma. Thank you.
Thank you.